Good morning, everybody, and welcome to Tuesday Training. I hope you're having a fantastic week. As always,
we are live from Austin, Texas, right here at Insurance Syndicate headquarters. And man, we have a great show for you.
yeah, that would help. Got to unmute my mic. All right, let's try this again. Good morning. Hope you guys are having a fantastic day. Now you can hear me, right? Yeah, I forgot to push this little button right here. Forgot about that one. But we are all good. We are all good. So good morning. We have a lot to talk about today. As you may have saw on the event invitation, if you were invited or you saw the cover photo or whatever, we are calling this the future of Medicare, because Medicare has a lot of stuff going on right now, right? Everybody is a little bit of flutter. There's a lot of buzz going on with changes that have happened. Some people are kind of freaking out and panicking. The sky is falling, some of that type of stuff. And other folks are just like, well, I guess it's just another day in the life of a Medicare agent. I can't go through everything that I would like to go through in this presentation today or in this discussion today, because we don't have the time to go through it all. I have done CE classes in the past on the future of Medicare. And I mean, I hate to say it in some ways, but pretty much everything that I predicted in that CE class. And if you saw me, it was, I did this talk or that same talk and slideshow at the first Medicare Con event in Vegas, where I gave a whole slideshow presentation where I took you back in history to look at all of the Medicare reform legislation that has been going on since 1997 to point to the direction we are here on purpose. We are not here by accident. We are here by design. And the future of Medicare is continuing on the exact same arc I told you about then. Nothing has changed. It is absolutely a bipartisan effort to move us in the direction of some form of universal health care. And it's been going on since 97. So we are going to talk a lot about that with some of the recent news that we've seen, a couple of articles. There's a really good article that we're going to lead off with that was written by former Representative Jim Greenwood. He was a Republican out of Pennsylvania. He was one of the original creators of Medicare Advantage back in the day. And he has some things to say about it. We're going to look at that. We're going to look at a new announcement that just came out from United Healthcare that has everybody kind of like, what is going on? Like Mike Capri, I don't even know how to say your last name, Mike. I apologize. But Mike in the chat is already talking about it. Yes, we will be discussing some of that, and I'm going to give you the facts on it, and I'm going to give you my opinion on what that actually means. We are also going to look at some new legislation that's being ponied up right now in regards to Medicare. And then we are going to look at basically a conversation that I had with ChatGPT last night talking more about the future of Medicare, the likelihood of a universal healthcare model, what is the likely opportunity, what is probably the most sustainable model that we might see, et cetera, et cetera. So we're definitely going to take a moment to look at some current things that are going on and some future implications, right? And what that might look like over the next 3 to 10 years, if that works for you. So with that being said, and jumping into it, the show is brought to you by DFY CRM. DFY is on the cusp of releasing DFY 2.0. And I'm super excited about it. I mentioned this last week. I already got to see a sneak peek behind the curtain, if you will, that Eric let me check out. If you're a DFY user, you're going to be extremely happy with some of the new stuff that he's bringing to you. And if you're not a DFY user, man, if you're looking for a good CRM, this is the one that I use. It's my CRM of choice. I've been in the industry 21 years, used all kinds of CRMs. This is definitely one of the best options for a white labeled go high level package. So with that said, let's jump into number one. Real quick, some news. Let me make sure I'm sharing that correctly. Perfect. Let's go. Boom. So this is an article, again, written by former Representative Jim Greenwood of Pennsylvania. He was a Republican of PA. It's obviously an opinion article, but he was on the committee that created Medicare Advantage or helped create Medicare Advantage, right? Says it right there. I helped create Medicare Advantage, and here's why I believe it needs reform. I'm not going to read the whole article for you, but there are a few areas that are definitely important. And I want you to see his opinion as someone that created it, because I would think, I'm not a legislator myself, but if I were a legislator and I created something, a bill or an item, a piece of legislation, I would have, it would kind of feel like that's my baby. I would feel very attached to it, right? I have the same level of attachment to some product development things that I've helped with in the past, right? That I wanted to make sure I saw them succeed because had a little piece of my name and my heart and soul in it. So same thing from this dude. So I take his comments, as very deep, very credible, very truthful, very honest. So anyway, it goes on and says, hey, in 2003, I helped write the Medicare Modernization Act, which established Medicare Advantage and added a prescription drug benefit through Part D. At the time, I believed that introducing private sector competition would spur innovation, improve care for seniors, and save tax dollars. I was encouraged by health insurance executives who asked me to be a champion for Medicare Advantage, and I agreed. I believed in the promise of a system where public-private partnership could deliver better results for beneficiaries. And then he says, more than 20 years later, I have to admit, the program no longer lives up to that promise. Now, before I go on further, I've made this statement before that if you're an agent out there and you want to sell Medicare supplement plans, and that is your belief that that is a more credible or more reputable, right, product to offer your clients, since it does give them national access, yada, yada, yada. And I'm not inserting this to have the argument of what's better, MAPD or MedSup. I'm just saying, if you have that belief that MedSup is the better product, I'm going to say it one more time. There is no shortage of bad press about Medicare Advantage that you can use to create your stance, create your point, create your content of why you believe your clientele should be purchasing Medicare supplement. There you go. Moving on. Medicare Advantage, he says, has become something quite different from what many of us envisioned. Instead of a vibrant alternative that drives efficiency and delivers value, it has evolved into a system dominated by a handful of massive insurers who are gaming the rules for profit. These companies are not small innovators fighting for better care. They are corporate behemoths raking in billions by exploiting a program meant to better serve our seniors. Overpayments and risk score manipulation have become endemic. The program's original safeguards against excessive billing and cherry-picking enrollees have proven too weak in the face of powerful lobbying, limited oversight, and manipulative practices that seemingly stay just within the rules. The result is that taxpayers are spending more for beneficiary under Medicare Advantage than they would in traditional Medicare, all while beneficiaries often face narrower networks, opaque denials, and delays in care. It pains me to say this, but the system we help create is being abused. So I'm not going to go through all of it. And he still agrees that, to be clear, I still believe private sector participation can play a meaningful role, but it's subject to accountability, transparency, and real competition. I'll put this in the group for you guys. Y'all can check it out, share it around, save it, etc. Do what you want with it. But I take his words to heart, and I don't disagree with him in a lot of ways, right? And I'm sure a lot of you probably don't either. But I think it's important that we're seeing someone who originally created the program now coming out and being a voice for reform, right? He's not necessarily saying he's completely against it, but he's definitely saying, hey, it was originally meant for this. It's being taken over by lobbyists and corporate behemoths, and it needs work again. It needs help. And now we have different things going on in the world, right? We have the Inflation Reduction Act that's doing things to adjust Medicare Advantage rules and drug rules. We have new CMS guidelines that are coming out regarding how prior authorization is handled, how the reporting on supplemental benefits is handled. So there are some reforms that are happening that I think will be good for it, but it's probably still not enough. Now, moving along, we're going to jump to the thing that has you all kind of in a flutter. It's big news. Mike already alluded to it. So you have probably, if you're appointed with United Healthcare, you have probably received this commission amendment update that just came out yesterday. The good news is for you, as it says right here, hey, no actions required on your part. This is going to be automatic. Basically, they have shot out a list, in case you missed it or you're living under a rock. UHC sent out a commission amendment update yesterday that basically says, in short, some plans will become non-commissionable for applications signed on or after July 1st for the remainder of 2025. It also says that upline commissions for some MA plans will be reduced for applications signed on or after July 21. And again, nothing you need to do. This is going to be automatic. We're automatically going to do this for you. Don't worry. That's a little humorous to me. But anyway, I want to just make sure you understand this is for applications signed on July 1st and after, right? This is not effective date. Some people are like, well, wait, I've got some UHC plans with July 1 effective dates. Are they going to be affected? No, they're not. It's for apps signed on July 1st and later. Now, the amendment goes on, and this is my MGA agreement amendment. So now you know what level I have and how I'm getting paid. Anyway, it goes through and it breaks down. First, it just tells you, hey, these are some updates, right? Initial year commissions for new enrollments for CMS Plan 2025. And I'm not going to read this whole thing, but it's basically telling you that, hey, starting July 1 for applications signed July 1, this is the new commission grid for you, right? None of the commissions change that much, right? There might be maybe there's some FMO level overrides that I'm not aware of anymore because I'm not at that level anymore that have thinned. But most of the rest of it is, as far as at least my level, I haven't seen any changes. As far as the commission amounts, right? Still getting 626, still getting my $75 override as MGA. No big deal. Okay. The problem that everybody's upset about, and I don't blame you, I get it. It's not a fun place to be in, is this list. It's a little over 100 plans, if you wanted to count them all, that are now non-commissionable starting for applications signed July 1st. Now, if you take a time to glance through this list, you will see that it's primarily PPOs, but there's also some HMO POS plans in there. And there's certainly some DSNP plans in there and some CSNP plans in there. Most of those that I've noticed, and I believe all of the DSNP and CSNP plans are all PPO also. I might, maybe if I go through it a little deeper, there's a PFFS plan in there. Who the hell's even selling PFFS anymore? That's out of control. There may be some DSNP HMO POSs that are in here as well. Like there's an HMO POS CSNP right there in Kentucky, right? So it tells you the plan number, it tells you the plan name, and it tells you the counties for which that plan is no longer commissionable. In some cases, you'll see right? Certain counties, in some cases, you're just going to see all counties in that state no longer commissionable. So, like as an example, if you're up there writing in Iowa, like you have these plans right here. You have 1, 2, 3, 4 plans now, 2 HMO POSs, 2 PPOs, 0 commissions on you or on those plans starting July 1 and later. Now, a lot of people are pissed about this, and I get it, man, because in a lot of ways you might feel like, hey, United Healthcare, they got a CEO that's making, I don't know what, 16 million a year or something, and they're taking away my commissions. I can understand that. I can definitely understand that to some level, right? Like, couldn't they reduce his profitability to help make these plans profitable? But probably not. That's stealing from Peter to pay Paul. The math really doesn't math that way long term, right? That's just a short result that we see when we feel like we're victimized from them taking away our money. I am of the opinion, and I'm not the only one with this opinion. There's a few others who have expressed this opinion as well, that this is not the insurance companies sticking it to us on purpose because they're like, screw the agent, right? This is not them using us as a mechanism to maintain profitability. Ultimately, it might look that way short term and it might feel that way short term. I can get that. My opinion is pretty simple. They as a business are not profitable on those plans. They're losing money on those plans. Now, if you're a business and you're an insurance agency, your job is to make money too. I know a lot of times we're like, no, our job is to help people. Well, if you're not making money, you can't help people. And the good news is the more money you make, the more people you can help. The more people you help, the more money you make. And it's a perpetual cycle, right? So UHC is stuck in a position based on government regulations, right? Added requirements, new regulations and rules for the things that they have to do and meet. Inflation Reduction Act was hammer time on how they created the math for these things, right? Like the math just doesn't math properly for these carriers to maintain profitability in certain areas, certain markets with the stuff that they are now required to do. So they have to make some changes. So what they're doing, again, this is my opinion, take it for what you want, right? Is they are trying to remove themselves from unprofitable positions. So they are now telling us that for these plans, we're not going to make money. We're not going to get commissions for these plans that we sell. Okay. Sucks for us. I get it, because now we've got 6 more months where we probably could be selling these plans to some of our T65s and people where maybe it's, at least on paper, it's the best looking plan for that client. And we really would advocate for them to get into that plan. However, these plans are not going to be there in 2026. I would bet you dollars to donuts that none of these plans that are on this list will exist in 2026. These are all going to be gone. They are going to consolidate all of these plans down to something that should be more profitable for them, likely, right? If they don't just remove them 100% and introduce a new product. But I would say they're probably going to condense these plans and so forth. I mean, as an example, like how many plans, in my opinion, whatever, there are certain counties where they just have too many damn plans. And I'm not talking across the entire spectrum. I'm talking about like individual carriers. Like, why does United Healthcare need 6, 7, or 8 different plans in the same county? Why do they need multiple HMOs, HMO PSs, and multiple PPOs? Why can't they have one really good HMO, maybe one good HMO POS, and maybe one really good PPO, and then a good D-SNP and C-SNP plan, and that's it. That's all you need. You just need to cover all, and that's my opinion. I know there's probably deeper reasons behind why they have all those plans, but we've already seen CMS start to take measures against D-SNP plans in order to reduce the number of plans that are out there. Right? They're trying to reduce the number of plans in the D-SNP market because they know that if they have all these different D-SNP plans that are out there, it's going to increase the level of churn. So we've seen them take 2 measures in the D-SNP market. One is efforts to start to reduce this total number of plans, and 2, they changed the whole SEP for it. So now, unless you're full dual and you have access to an integrated plan in your area, you fall under the same change guidelines that everybody else in a regular MAPD does. You are now just able to use, other than your IEP, you're able to use AEP, OEP, and any SEP that you might qualify for, right? Now, if you're full dual and there's a HIDE or FIDE plan in your area, FIDE or HIDE, right? Highly integrated or fully integrated plan. Now you can move into that plan and you can move every month, right? So if there's multiple integrated plans in your county, theoretically, you could still churn a lot, but there's not that many fully integrated plans in a lot of these counties because generally only one or maybe two carriers at most, depending on the size of the marketplace, have the integrated Medicaid contract. So that is an effort to reduce churn. And I think some of the other measures and some of the regulations that they've created are driving towards the same factor. And it's going to force some of these carriers not to have so many plans, but narrow it down to some solid, strong options that they can get behind and present, which we as agents, like I would welcome. I would love if there was only a couple of United Healthcare plans, a couple of Humana plans, a couple of Aetna, and a couple of Anthem. And most of it was driven, certainly by the level of benefits and the different networks that were behind those plans on what was going to serve my client the best. I would have less churn. I would have less agents coming in behind me and trying to kite my business by abusing SEPs and other things that we know they're doing. It happens everywhere, right? So I feel like if we could reduce the number of plans, we would have better outcomes and better retention as an agent. Just my opinion. But I know a lot of people are pissed about this. They're like, these carriers just keep stealing our commissions, yada, yada, yada. Yes, we've got plenty of examples. We got WellCare snagging all of our PDP commissions, and not just for new business. They went back and said all your renewals too, which would cost friends of mine like Danielle Kunkel and Mike Weller and Keith Knabb and some of these guys, cost them a lot of money because they had a lot of business on the books with those carriers. We got UHC telling us they're not paying commissions on PDPs anymore. But like, do the math. You should know that they can't pay on the PDPs anymore. Inflation Reduction Act completely wrecked it for them. Completely wrecked it for all of us. And ultimately, more beneficiaries are paying more for their prescriptions overall than the small percentage of beneficiaries that legislation truly helped. That's my opinion. So that's it on UHC. I'm not going to talk about that one anymore. I'm just going to tell you again, my opinion is that they're not trying to screw you and take advantage of you. They're trying to get themselves out of an unprofitable position so that they can increase their profitability so that they can better serve their customers and hopefully better serve agents as well. We'll know for sure in the future, but I'm going to tell you, dollars to donuts, you're not going to see any of those plans in 2026. So we might see some footprint shrinkage, but I think we'll definitely see plan consolidation and a reduction in the total number of plans. If I had to guess, we're also going to see fewer, if any, zero premium PPOs. I would bet your give back PPOs are probably on their way out the door for all you guys that are just selling give backs because it's the easy thing to do because you don't know how to present real value. I mean, if you're selling give backs, first of all, and you're not wrapping in ultimate or additional coverage through hospital indemnity, cancer, home health care, something of that, like you're totally missing the boat, number one, because you're really not taking the best care of your client, in my opinion. But I know I get it. Like some clients are just like, dame le pinche give back plan. That's what I want. I'm like, all right, I'm not going to argue with the marketplace too much. I'm just going to sell it what it wants. Enough on that. Moving along. This one's rather interesting as well. And this was already shared in a couple of the groups. Let me get it up on stage or on screen for you real quick. As if we need another piece of Medicare, Democrats have now introduced a bill to establish Medicare Part E as in Edward. So now we might have Part A, Part B, Part D, Part C, and Part E. Part E excites me and freaks me out at the same time. Because Part E is pretty much everything that I've been talking about in regards to the future of Medicare when I stepped on that stage at Medicare Con in Vegas and gave this presentation about my prediction for where we're headed in the future of Medicare, and that was based primarily off of the legislation and the overall arc where I saw it going, which we'll get into a little bit more. I need to move on. But Democrats introduce a bill to establish Medicare Part E, a public option, as it says there at the top. Democrats in the House and Senate have introduced new legislation that would establish Part E for Medicare, which would allow people to opt into the program. We have Representatives Jimmy Gomez from California and Don Beyer of Virginia on Monday put forward the Choose Medicare Act. Choose Medicare Act. Under the proposal, a potential Medicare Part E would have the program compete with private insurance. Democratic Senators Jeff Merkley of Oregon and Chris Murphy of Connecticut introduced a companion bill in that chamber. Medicare Part E, as outlined in the bill, would sustain itself through premiums, with enrollees able to sign up through any state or federal insurance marketplace. Any existing subsidies available from ACA plans would be applicable for Part E coverage. The bill would also allow employers to choose and provide Part E coverage for their workers. Our bill would give all Americans access to Medicare. In other words, their bill is Medicare for all. Our bill would give all Americans access to Medicare, one of the most popular and successful healthcare delivery programs in history, allowing employers and the general public the option to choose Medicare would say that again, allowing employers and the general public the option to choose Medicare would fill many of the gaps in our healthcare system, get more people covered, and make the nation healthier. Plans would be required to cover the ACA's 10 essential health benefits and include a full range of reproductive health services, including abortion. In addition, the bill would establish a cap on out-of-pocket costs for traditional Medicare and allow the program to negotiate drug prices. The Part E coverage would also include consumer protections against surprise Medicare bills, the announcement said. The proposal echoes the long-standing Democratic push for a public option or a government-backed insurance product that would compete directly with private insurance plans. Some states have already rolled out public options for residents, and results have been mixed. That is the end of that little article. Results have been mixed links us to another article, which is here. And this is an older article from April 11th of 2024 that says state public option plans don't reduce premiums. They result in low enrollment and industry based on an industry-backed study. So again, that previous article I just showed you, right, regarding Medicare Part E, said some states have already introduced state public plan options and results have been mixed. And this study here says, well, those plans don't reduce costs and they generally have very low enrollment. Which ones are we talking about? Well, instead of enacting public options plans, states should target reinsurance programs, is what the Partnership for America's Healthcare Future argues. Now, if we scroll through here a bit, we will find, number one, that the Colorado public option plan, if any of you are in Colorado, let me know what you think about that plan. The Colorado Public Health Plan option has had premiums lowered 30% to non-option plans, and 49 states experienced decrease compared to 2021 levels. So they're saying, hey, it's saving us money. But then to go on, this study that they put together said, well, wait a second, that may be true, but we're only finding 15% of plans in Colorado actually even met their initial year premium targets, right? What they're trying to earn. Moving on, this little statement here, in 22 and 2023, aggregate premiums for Washington's state public option were $2 million more than if public option participants had just chosen the lowest cost non-public option or private. In Colorado, that figure was $13.3 million in 2023. It goes on to say that states have failed to meet their premium targets in part because policymakers have been unwilling or unable to secure sufficiently low reimbursement rates. In Washington, the state set the reimbursement rate at 160% of Medicare level rates. And in Colorado, the state implemented floors on hospital rates. These policies created unintended side effects. You don't say. As a result, public option plans in Washington and Colorado enroll less than 1% of their state's population. Nevada's public option doesn't begin until 2026, though projections indicate the state will have to cut hospital reimbursement rates and establish rules on insurers' administrative costs to meet their premium reduction goals. So again, mixed results on the public options, which is what the Dems are trying to do with Medicare Part E. Okay. Now, if any of you were at Medicare Con, the first one in Vegas, where I gave my presentation on the future of Medicare, or if you've attended one of this, actually, I did it at Christian Brendel's event as well a couple of years ago, and I've done it as a CE class a couple of times. And yes, Mike, I will be posting those in the group so you can grab them, study them, share them, do what you want with them. But if you were at either of those events or happen to attend one of my CE classes through NABIP that I've done on this a couple of times, again, it's based on looking at legislation going back all the way to 1997, the Balanced Budget Act, when they first created the opportunity for Medicare to then contract with private insurers. And then since then, every single administration along the roadmap has done something to pick up that little piece of information and move it along the road a little further. Certainly, they're inserting some of their own agendas along the way. But what I'm saying is that the privatization, if you will, of Medicare and the drive towards some type of universal healthcare model has been a bipartisan effort in different ways, right? Every time they take what was left over, they're like, all right, we need to move this a little further down the road because this is a goal that we have to get to at some point. So what can we do as an administration to tighten it up, clean it up, put some better bells and whistles on it, some to help us get elected next year, and just move this little thing down the road a little further. So a couple of things I want to look at real quick. Number one, looking back at the Medicare Part E thing, one of the statements that it said was that it would have to cover all 10 of ACA's essential health benefits. Just to run those down for you in case you don't know what they are. So Medicare Part E, should it get created as a public, I want to be clear, this is a public option. So Medicare Part E is just another version of original Medicare, basically, but they're kind of modeling it after the ACA. Kind of weird. I think I made that prediction a few years ago. But moving on, here's the 10 essential health benefits that their Medicare Part E would have to cover, just like they're required to do under the ACA. Number one, ambulatory patient services, right? Outpatient care, et cetera, et cetera. Number two, emergency services like ER visits and ER transportation. 3, hospitalization, right? Coverage for inpatient care, pregnancy, maternity, and newborn care. Mental health and substance use disorder services would have to be included. So that includes behavioral health treatment, counseling, psychotherapy, et cetera. Prescription drugs would have to be included in the plan. Okay. Rehabilitative and habilitative services and devices. So these are services and devices that help people with injuries, disabilities, chronic conditions. That would have to be included, just like it is in the ACA. Laboratory services. So that's all your labs, your MRIs, x-rays, et cetera, pretty standard there. Preventive and wellness services for chronic disease management. So this is coverage for preventative care services, vaccines, screenings, managing chronic conditions. And then finally, pediatric services that includes coverage for children's dental and vision care, wellness visits, immunizations, all the way through, but adult, it says, a little claim here, says adult dental and vision are not mandated as essential. So Medicare Part E wouldn't have to cover dental and vision for adults, but it would have to cover it for children. So what are they really talking about here, right? They are talking about creating a plan that would be available to everyone as a public option to enroll in, right? We're basically based on your income or lack of income would determine your premium subsidies, just like it is in ACA. And it's designed to compete directly with private insurance companies, such as Medicare Advantage plans, Medicare supplement plans, et cetera. What they don't talk about in the bill that I've seen so far, anything that I can find, and there's very little information out there currently, is that what they would do with the original Medicare and what would they do with the ACA market. If they're going to create a Medicare for all public option through Medicare Part E, and it has to cover everything that ACA covers, isn't it just ACA coverage? Except that it's also available through employers, and then people on Medicare can choose it instead of original Medicare. So with all of that said, I decided to have a conversation with ChatGPT yesterday. Because I'm like you guys, man. I've been in this industry 21 years. I might have a little more industry knowledge than the average bear. I might have seen a thing or two a little more than some people that haven't been in as long. But I still have some of the same questions floating around in my brain that all of you have right now. I'm no illusions in that. Is AI going to replace us as agents? And if it is, like when? Like how long is that going to take? Is Medicare going to kick us out of the game where they no longer need a broker anymore? Whether it be because we've been replaced by AI or just because carriers quit paying us commission so they force us out? Are they going to go to a universal healthcare model that no longer needs agents to support it and move it? I started wondering, and I'm pretty knowledgeable, but like understanding all of the moving parts involved in that and the money and the math, like I don't have that deep of knowledge, right? I'm not that far behind the scenes. So I decided to have a question with ChatGPT. Let me put this on screen for you guys as well, so y'all can see some of it. So it might be a little too small for you guys to read, but I'm going to go through it in pretty good detail and give you guys some information. So basically what I asked it was like, hey, ChatGPT, what do you believe the likelihood is that some form of universal healthcare or Medicare for all would get passed in the U.S. within the next 3 to 5 years? Or how about the next 7 to 10 years? And do you believe a universal healthcare model is even possible or sustainable in the United States? And it said, great question, yada, yada. And then it says likelihood in the next 3 to 5 years, very low, probably a 10 to 20% reality. The political reality is that neither major party has enough consensus to pass sweeping reforms, while progressive Democrats support Medicare for all, centrist Democrats and nearly all Republicans oppose it or prefer incremental reforms, right? So it'd be a massive upheaval to all of a sudden just move us in the next 3 to 5 years to universal health care in some form and wipe out all of the other healthcare options. Control of Congress, even if Democrats win the presidency without a supermajority in the Senate and House, a full Medicare for all bill, very unlikely to pass. Industry influence, powerful lobbying from insurers, pharma, hospital groups remains a major barrier. Like none of them want it either. Now, looking at it the next 7 to 10 years, what's the likelihood? And it's like moderate. Not even 50%, though. It's like 30 to 45%. Now, because in the next 7 to 10 years, we have changing demographics, younger generations would be more supportive of universal healthcare models. State-level experiments like states like California and Washington, Colorado and Washington already doing it. Nevada's rolling one out in 2026. States like California and Washington might test models that eventually build momentum. I don't know that these plans are building momentum, but they're definitely states that are trying public option plans, which is it's their way to test the opportunity for a Medicare for all. Economic pressures, rising healthcare costs may force bipartisan reforms, potentially leading to a public option or hybrid universal model. Then it says possible scenario, expansion of ACA subsidies, stronger public option, or automatic enrollment for low-income uninsured groups could evolve into something functionally universal without being called Medicare for all. Next question that I asked it says, hey, is universal healthcare model even possible in the U.S.? And it's like, yes, it is, but not necessarily a single payer system like Canada's. A uniquely American hybrid model, similar to Germany's multi-payer system, is more feasible politically. It would likely involve regulated private insurers alongside a strong public plan automatic enrollment, and price controls. Incremental expansion of Medicare, Medicaid, or ACA provisions could result in near universal coverage without dismantling private insurance entirely. Is it sustainable? Yes, if it's structured properly. The US already spends more per capita on healthcare than any other nation, yet has worse outcomes. Redirecting funds from inefficiencies could sustain a universal system. The US already spends more per capita on healthcare than any other nation, but has worse outcomes. I want to look into that one more. I thought we had the best healthcare on the planet, or at least medical care, like we have the best doctors, best providers, best surgeons. No? Wouldn't that mean better outcomes? Or is that probably just for the people that can afford those things? So as a collective, we have worse health outcomes? Or are they looking at that? Are they including the fact that some people who haven't even been in the healthcare system yet, like truly like in it, because they don't have a chronic disease or something yet, but they have chronic diseases, obesity, diabetes, things like that. Is that maybe are they talking about it from that angle? Because we continue to feed ourselves trash. Sorry, I digress a little bit there, but that made me think. So it says that redirecting funds from the inefficiencies could sustain a universal system. Administrative costs are high in the US due to complexity. A universal model could reduce that. Sustainability hinges on controlling drug prices, provider cost, and administrative waste. Where have we heard that before recently? Bottom line, a full Medicare for all system is politically unlikely in the near future, but some form of universal coverage, particularly via a public-private hybrid model, is increasingly likely and economically stable in the long term. Then it says, would you like to see a side-by-side comparison? I'm like, sure, let's go. So it brings me some examples, right? And it basically says the first one it points at is Canada's single payer, right? It's obviously it's funded by by government taxes. If the US were to apply that, it would be a major overhaul. Not going to happen here. Like, we're not going to get that level of tax reform to create a single payer system. Not to mention, we already have issues because if it's government run administration, that's going to be opposed by insurers, as well as people like me that don't necessarily trust the government to handle that on their own. Moving on, let's look at the Germany and Japan. Funding is by mandated employer or employee contributions. If we looked at that in the US, that could be expanded from current employer mandates. The administration is done by multiple nonprofit insurers, sickness funds, as they call them. That could mirror some of the ACA exchanges or Medicare Advantage model in US application, it says. The private insurance role is integral, but highly regulated. That kind of fits with the US tradition of private insurance. Provider status, mostly private, aligned with our current system. The likelihood in the US, moderate to high, but long term. Like, it's going to take a while to get there. And politically, it's the most politically viable hybrid solution. Same thing with the example that it's given us from France and Netherlands. The funding, general taxation, payroll taxes, similar to potential Medicare expansions here in the US. The administration in France and Netherlands is government, but also supplemental private plans, Medigap plans, things like that. Closely resembles ACA plus a public option. The private insurance roles are not primary payer, but supplements. And it's an easy path, minimal disruption here in the US. Provider status, again, public plus private options. Still kind of aligns with what we're doing to some level. Likelihood in US, very high as a reform pathway. Could evolve from the ACA Medicaid expansion. Public option or Medicare buy-in. Voluntary premiums plus subsidies would be the funding. That would attract younger or uninsured people, right? Especially if they have voluntary premium or subsidy because they're not making any money, so they get it for free. Administration government run option within the ACA or Medicare framework. It preserves private plans but increases competition. So it gives us a few options there that could be, and it says that obviously our highest likelihood through a reform pathway would be a public-private option similar to what they're doing in Germany, France, Japan, and the Netherlands. Key insights on this. It says a full single payer is ideologically appealing, but structurally unlikely in the near term without major political upheaval. Yeah. A multi-payer or hybrid system, again, like Germany or France, offers a more realistic, incremental path toward universal healthcare that Americans could accept. But again, it's going to take a long time to get there. They've been working on it since 97, by the way. I've told you that a few times. Like, just look at the reform legislation. It doesn't take a rocket surgeon to put that arc together, right? So incremental changes every 2 to 4 years. And then it goes through some messaging stuff. But here it gives us a concept here. It threw out this concept of universal Medicare base plus private flex options. This is pretty interesting. So under a universal base coverage, everyone is automatically eligible for the public health plan modeled after original Medicare. It includes Part A, Part B, and Part D, or a consolidated equivalent. Coverage is national and portable, just like Medicare today. The premiums are income-based. Sliding scale of premiums and cost sharing subsidized like ACA or Medicare IRMA. Low-income individuals would pay little or nothing. Higher-income households contribute more. It eliminates the need for Medicaid as a separate system because it folds it now all into a unified base. Optional private upgrades. Individuals can stick with the public coverage only, like original Medicare, or they can buy a supplemental plan, like a Medigap plan, or they can choose the private alternative, like a Medicare Advantage plan. These private plans would be regulated, required to cover at least what the public plan does, and be allowed to maybe offer some level of extras. Why this is viable? It mirrors Medicare's existing and widely trusted system. It maintains private market choices, addressing concerns of those skeptical of full government control. It has built-in cost controls. The government can negotiate prices, as it's already starting to do with Medicare Part D, driving down national health care spending. Public trust. Medicare is one of the most popular government programs across all party lines. Equity and flexibility. It ensures that no one is uninsured while still respecting individual choice. Ease of implementation. It builds on the current infrastructure, CMS, Social Security, insurers, avoiding a total system overhaul. Potential challenges: industry opposition, phase-in periods, preserved private market for plans and providers. So it's going to take some time again. Federal-state integration would require gradual Medicaid merger from buy-in states. So again, this is going to be a long process if they try to do this, which I'm of the opinion they're already trying to do. Cost perception. Messaging would be focused on savings from admin efficiency and price negotiation. It even says, hey, possible names, frameworks already floating. Medicare X. Haven't even heard about this one. But Senators Bennett and Kane. Choose Medicare. We just heard about that one, right? Medicare Part E is the Choose Medicare Act, or Medicare for America, and then it comes up with some bullshit, ACA 2.0, yada, yada. Bottom line, a universal-based public plan with income-based premiums plus private supplemental options is the most realistic version of a Medicare for all that could actually get passed in the U.S. within the next 7 to 10 years. It combines universal access with market freedom and leans into the most successful elements of current Medicare system. Mock policy. Universal Medicare Choice Plan. So this is a mock policy that it put together. It's got a lot of similarities to what we already have, but I found it super interesting. Number one, universal enrollment in a public base plan. All legal U.S. residents are automatically enrolled in a basic public health care plan upon turning 18, moving to the United States, or losing other qualifying coverage. The base plan is modeled after original Medicare A, B, and D, and it's administered by CMS, available nationwide. Again, income-based premiums and cost sharing, Premiums are set on a sliding scale, very similar to ACA subsidies and current Medicare IRMA brackets. Might be $0 a month for someone under 150% of poverty level, and that's subsidized up to 400% of poverty level. High earners pay a higher share. Deductibles, this is the one that's, I think, a little different. Deductibles and copays are tiered based on your income and family size. Interesting. Private supplement options. Individuals can purchase a private supplemental plan like Medigap to reduce or eliminate their out-of-pocket. Plans are regulated, standardized, and portable. And then you have a private alternative like Medicare Advantage. Consumers may opt into regulated private comprehensive plans that offer greater or equal coverage than the public base plan. The private plans may even offer additional benefits, like we've seen this before. Provider freedom. Participants can see any provider that accepts Medicare. We're already in that space, right? So some of this, again, is very similar, but some of it a little different. No network restrictions in the base plan. Private alternatives might use networks, but must maintain certain access standards. It's a simplified system because it consolidates ACA, Medicaid, and CHIP into one unified system. Seniors remain on traditional Medicare, but can transition to the new structure. Funding mechanism. Combination of redirected existing federal healthcare spending, employer and employee payroll contributions as it is in Medicare today, income-based premiums, and additional revenue via closing tax loopholes, sin taxes, or wealth taxes. So that is a conversation that I had with ChatGPT yesterday on the likelihood of creating a universal healthcare model. Is it possible? Is it sustainable? How long might it take? And then here it says, don't you feel like the current administration is going backwards in the under 65 market by letting expanded subsidies expire? Yes, to some level I do. And again, but we're not talking about the ACA space, and I'm not an ACA expert. I'm more a little line in the Medicare space, but I do understand what you're talking about with that. But going backwards, like some of it, they're going to have to unwind if they're going to wind it back up into something like I'm talking about here. And I don't, it's not going to be this presidency. It's probably not going to be the next one. I would say it's going to take a consecutive two-term administration. So if it were me, I would look for it in about 12 years. I think by the time we get to the end of what is that, that'll be 2037, somewhere right in that space, I bet we'll see universal healthcare on the table, big time. I've talked about it before. I'm talking about it again. So my prediction is pretty much exactly what ChatGPT just put out. I've been talking about this for a while, is that they are going to incrementally push towards a unified system that combines Medicaid, Medicare, and ACA into one universal healthcare model for everybody. That public option, right, that you're automatically enrolled in as a citizen that turns 18 years old, is going to be subsidized based on your taxable income and your family size, and that'll be your premium. If you want, you'll have some private supplemental insurance options that you can use to plug some of those gaps. Or if you're like, the hell with this plan, I want that network plan they've got over there that's all in one, and just like Medicare Advantage. And then they're going to model it after Medicare Advantage, and people can have, I don't see them doing it any other way. We have too much of a political divide in this country to all of a sudden just go all the way one way or all the way. They're going to have to make a compromise and meet in the middle with a public-private hybrid option. Period. I think that's where we're headed. 100%. And what I really hope is that they'll do it with a real direction to improve our own, improve our health and our health outcomes, like truthfully. Like one of my thoughts, and they do a little bit of this in the Medicare Advantage world, but not to the extent. I would love to see it, right, where your plan option that you have, whether it's the public or the private one that you end up with, was designed in such a way that your behaviors were rewarded with money, basically, through your flex card, right? A lot of these plans have a flex card. So what I would love is that when you go to your primary care doctor and he's like, bro, You're borderline tachycardia. We got to bring that heart rate down and your blood pressure. Here are some lifestyle changes that you can make to do it naturally, or I can just prescribe you this drug. However, if you're willing to do it naturally and you'll go through these steps, as you go through those steps, you're going to get rewarded with flex points on your card that you can then use to pay for more things that increase your health outcome, right? Not just go buy golf clubs, not use it for gasoline or your electricity or shit like that. Everything has to be wound into a compounding improvement of your health outcome. So, for example, if you're borderline tachycardia, as an example, which means that your heart rate is like resting above 100 most of the time, and they're going to say, hey, we want you to go to the Tai Chi class or the yoga class, pick either one. We also have a meditation class you can go to, right? I want you eating these foods. I want you eating more potassium because that's known to lower your heart rate. So if you go buy the organic bananas at the grocery store that's part of one of your network providers, you're going to earn more points on your flex card. When you check in at the Tai Chi class, you're going to earn more points. You can use those points to go buy more of the organic bananas or the other items you need. And every time you do it, it's a self-rewarding system that is all designed to improve your health outcome. That's my thought. Maybe that's a little too utopian. I don't know. But there you have it. There's some interesting info. And in short, here's the thing that I say all of that today to sum up with this. You're fine. Your business is not going anywhere anytime very soon. They're not getting rid of us. We're not going anywhere. Medicare market is not falling apart. It is evolving at a rapid rate, and it's incumbent upon you to keep up with it and evolve your business, right? I talked a lot yesterday in our morning meeting here about change. And one of the things that Bruce Lee's philosophy is that when change comes, you have to change. And if you change with change, you're in the changeless state. A little mind blowing, but it means that like when change happens, you have to change too to keep up with it, right? So we have to make some changes in how we approach the marketplace and what we're doing to continue to keep up with the changes happening. But they're not getting rid of insurance agents. They're not getting rid of the Medicare market. It's not going away. It's not falling apart completely, but it is changing. So just learn to pivot, right? Maybe build in some other revenue streams to prepare yourself for what probably will happen in the next 10 to 12 years. Pretty simple. That's Tuesday training. Have an awesome day.